Everybody, and welcome to all the pediatric hemato-oncologists for our second virtual session in Essentials of Pediatric Palliative Care. So today we have the class on pain assessment management and multimodal analgesia. So it's my great pleasure to introduce Professor Dr. Gayatri Palat, who's the HOD and Professor of Pain and Palliative Medicine at MNJ Cancer Hospital, Hyderabad. She is the pioneer of pediatric palliative care in India. She's a teacher par excellence and a global leader in pediatric palliative care and palliative care. I'm also lucky that I'm working with Dr. Gayatri Palat. The next speaker is Dr. Kritika Rao. She's a dynamic palliative care physician with special interest in pediatrics and also takes care of the pediatric palliative care program at Kasturba Medical College, Manipal, Mahe. So over to you, ma'am. Thank you.
Thank you very much for the kind introduction. I request Dr. Kritika to start the session.
Just sharing the presentation. I was wondering that before we start with the actual presentation, I had this profound quote that I read from Kate Middleton herself. She's currently, we know that she's got diagnosed with cancer herself, and this was one of her visits to the hospices in UK, where she said that, having delivered the best possible palliative care to children is vital, and providing children and their families with a place of support, care, and enhancement at the time of their great need is simply life challenging. And I believe all of you here welcome you to this course, and I'm really excited to have this interaction with you along with Dr. Gayatri ma'am as we take you through this session today, which is about pain in children with cancer. And I and Madam together will take you through this course where we're going to be looking at how to assess pain and also manage pain in children with cancer in various situations. So I would like to start with this particular case. A child, let's say his name is Mohan, 6-year-old, diagnosed with ALL. And he's there sitting. You can see that there's a room, and he was he was sleepless, he was irritable, refuses to get down from his mother's lap. Now, have you come across such situations often in your practice? Feel free to unmute yourself and say, or even put it on the chat. How many of you see a scenario in your practice? Or do you see or not? Right?
Yes.
And
So
what do you think is here happening? Very often, they cling to their parent, they're anxious, they're fearful. And this situation, what could likely be happening if you can just imagine if this situation is there in front of you? Yes, they are scared, they're fearful and anxious because they're in a hospital environment. They do not like that environment because they have probably bad experiences. Pain, yes. One of those experiences would be previous visit to the hospital would have been very painful, very distressing, and they have a lack of trust amongst the healthcare people because they're those who are the villain in their story. So fear of needles, absolutely. So many of the children, if they present to the hospital, will never like to walk into a doctor's chamber, and they're always very irritated and they'll cling to their parent. And so often than not, this happens on a routine basis every day. Every third, fourth child walking into your OPD with a diagnosis of malignancy or undergoing diagnosis of malignancy will face a lot of, pain or painful procedures, or pain due to the malignancy, pain due to treatment, and so on and so forth. So when we talk about pain, it is most debilitating. It is one of the most important factors that affects the quality of life of a child with cancer. And it's not because it's just one time, it's a chronic pain. Children go through some issues which are acute because of a procedure. You might do a phlebotomy procedure, you might do an IT, you might have a bone marrow biopsy, you might have a surgical procedure being done. It could be even chemotherapy, port access, everything could be pain for the child. And for a child undergoing cancer directed management, this pain is prevalent throughout the child's course of illness and in beyond, even in survivorship and so forth. So, which is why it is not just only experienced in advanced stage children. Presenting with pain itself is one of your possible presenting symptoms that they would come at the first time that they walk into your clinic, and that would make you think about why this pain is there, and then so on and so forth. You evaluate and you find out that the child has malignancy. So it is one of the most important factors that we need to really look into, and that's why it's called as the fifth vital sign. So there are certain myths that we, commonly see across, when we talk about pain in children, especially if you talk about infants, neonates, it is assumed that they are neurologically immature yet. So therefore, they do not have pathways developed where pain impulses can conduct up to the thalamus and to the cortex, and their perception of pain is as according to a normal, fully grown adult, or a grown up young adult, adolescent, or a young adult. It is not that. And also we feel that infants may not remember the pain because immaturity, there is neuroplasticity going on, so there would be changes happening and things would not register. Or children are so active in playing, or they're sleeping, and if you were to do any procedures while they're playing, or so then it will not report pain. Or the child is active, so the child is not in pain. Or the child is sleeping well, so the child is not in pain. So it might so and so forth happen in our practice because over the course of years, things around us, our culture, the way we manage in our setting, in our context, we come to believe that maybe, yes, all children may not have pain if they are not reporting it. So, to clarify some of those myths, we take you through this particular class. So, one of the important aspects about when we talk about pain in children versus an adult versus a child, an adult, as you all of us know, we can tell we have pain. We will be able to verbally describe it. Even non-verbally, our body shows signs that we are in pain. We're able to locate. We're able to tell the severity, the character, the intensity, how it fluctuates, where it starts, where it goes. We are very descriptive about it, and we are able to do that because of our experiences in life, and we understand how pain is perceived by us. Whereas compared to a child, for a child, if it's first time experiencing that pain and they may not understand, depending upon the child's neurocognitive status, child's neurodevelopmental status, the age of the child, it all depends upon whether they're able to report it or not in the first place, able to talk it out verbally. They may find it difficult to tell you exactly where it hurts. Sometimes they're afraid to tell you if it hurts because the fear of what will happen if I tell if it hurts. Probably their past experiences at home would have impacted that. If they would have told the parent that if it hurts, they might have been scolded because they did something wrong. They might have created some mess at home, and that's why they worry that if I tell if it hurts, they might punish me for that. Or they might just not tell you what happened, but they just say it hurts. So it's pain, or is it hurting, or is it something is there? They're not able to describe that. Which is why sometimes it can be a challenge for us to really get in a correct history or a reliable history, and thereby we are unsure whether this is a symptom prevalent or not. So basically the definition is that pain is whatever the experiencing person says it is, existing whenever the child says it does. So we often have that in our practice sometimes in way that we look at the patient and we decide sometimes whether, oh no, the patient is, I mean, the child is saying that yes, he or she has severe pain, but is very calm and quietly sitting in their mother's lap. And we assume that if a person is in pain, will be howling, shouting, crying, wailing, groaning and moaning, and this is completely opposite. That can happen over a period of time where certain behavioral changes and all occur. So always we tell is what is painful to an adult is painful to an infant and child unless proven otherwise. So we always want to believe the child, believe the patient that if they say they have pain, we take it as is, and we can corroborate it with the parents, that because you are going to hear it from the child at one point of time, we can always check in with the parents, have their understanding as well, whether how has the child been in the past 1 week, when have these episodes occurred, and so on and so forth when you take further history. So when we talk about pediatric pain assessment, as I just mentioned earlier, it is a whole patient assessment, mainly because of that children do experience pain right from birth. They are able to. So even it is practice that, in the neonatal phase, they might not perceive it, or there is no memory forming of pain, but it has over a period of time shown with studies and how pain, if it is not controlled early in life, or they've been exposed to these episodes multiple times, it can form, memories of it, and that can affect later in terms of their behavior, their experiences, and overall. So as we know, overall pain perception starts with a noxious stimuli, physiological transmission, sensory perception of pain in the cortex, and then that is how it affects overall our experience of pain. So that's the sensory component. But there are other dimensions in terms of when we talk about broadly as cognitive, affective, and behavioral. So when we talk about cognitive, it could be influenced by how parents also respond to that pain. Now, amongst the audience, many of you have kids. I don't know about it. I'm not asking, but some you may have kids at home, and they would have hurt themselves. How do we all respond? Some of us respond in a way that we react to the child in the same way the child reacts. Even we might use words, say like ouch, and we make certain in our own language, we may have certain words that we call out for what is pain. If we react in the same way as they have reacted, they understand, oh, this is something that's bad and it's painful, or it's something that is affecting me, and they might respond to it that way. Versus someone that they see that the child is in pain and they remain quiet, they don't react, they let the child understand it, and then they explain it. Or we might talk about, oh, you're a strong boy or you're a strong girl. You should not cry when there is pain, and you should not be able to cry like this. It'll come down, sit down, whatever. We try to pacify the child. So it's our beliefs, how our attitudes are when we experience, so that the child learns from the parents and their peers around them. That is how also it affects their ability to understand or perceive what pain is, emotions, what we show, and behavioral changes that occur over a period of time if the child is persistently exposed to a painful stimuli. Say children undergoing cancer treatment due to multiple pinprick procedures, hospital visits for chemotherapy, or disease related or treatment related or drug related pain that occurs, that all affects the emotional component as well. Together, this has an influence over how a child would perceive pain. So now coming back to this child, as I initially said, Mohan was diagnosed with ALL. He presented. Now he's undergoing induction, and he complains of back pain, leg pain. And on asking, on a faces pain scale, he says pain is 8 on 10, which is where he is very irritable because the pain has been very severe, refuses to get down from his mother's lap. What do you possibly think would be likely causes of pain here? You can chat, you can even unmute. The disease itself, yes. Steroids, infiltration, yeah. Drugs. So a lot of you have talked about disease, treatment, therapy, procedures being done, lesser physical movements, depends on what time point, yeah. Hypertension would be the reason for irritability, multiple injections and pricks. So as you have very rightly identified from your perspective itself, that all of this can affect the child's well-being, and child could be reporting pain due to various other causes. So another reason why assessment becomes very difficult in our situation, because pain can be multifactorial. It has a lot of different etiologies for a child undergoing cancer treatment to have pain, and which is what it makes it challenging for you to also understand how do we look at management, what do we address first, how do we address it, and so on and so forth. So that's how we're going to take you through, and Gayatri Madam will take you through the management of such complex pain with using different methodologies together. So when you talk about multidimensional aspect of total pain, as I earlier talked about how pain is influenced with affective emotions, cognitive behavioral changes around them, there are other factors also which add on to how pain is perceived. And some of it could be related to their socio-cultural background, what is the kind of coping style the parents would have had, and similarly how the child would have learned. I'm talking about an older child, somewhere beyond 7 years of age, who's able to understand and perceive and learn from his family surroundings. What is the family dynamics? Both the parents being together, parents are separate, or the child is living with some other guardian, not with the parents. What is the caregiver's perspective overall, and so forth. So when we look at pain, and in terms of chronic pain, complex pain, pain may not only be physical. There is a multidimensional approach to it, that it could be a total pain where there is a physiological cause for it, but there's also a lot of behavioral factors, socio-cultural, cognitive attitude in terms of what do they understand of pain, what do they make a meaning out of pain. For some, pain could be punishment. For some, pain could be that it's routine as part of their illness. Parents may also say that my child is suffering because I did so and so in the past, or probably this is my karma that is transferred on, so they have to bear it. So, all of this is also sometimes perceived by the child, and they may respond or react in that situation. So, the age, the development, the past pain experiences, the fear around things, the cultural factors, and the parents' perception all influence how the child is going to perceive and report pain to you. So, common causes would see about procedures, as you talk about skin breakdown, infections. They may have diarrhea leading to perineal excoriation, abdominal pain in children undergoing cancer treatment because of GI mucositis or vincristine-induced neuropathy, sores or abscesses that they develop during chemotherapy, headaches because of, as we talked about, neuroirritability could be due to hypertension, press that they would develop, or steroid induced. Limb pain could be probably chemotherapy induced, joint pain, oral infections, nerve pain. So when we talk about all of this together, it's multiple causes could exist at the same point in time. And that's why assessment of pain and then managing each aspect becomes more and more important. So the basics is that we ask about the pain regularly and assess the pain systematically. We believe the patients and the family in their reports of pain. We choose the appropriate agent, and we deliver the interventions in a timely, logical, or a coordinated fashion. And that is done by empowering the patients and their families and enabling patients to control their course as much as possible, age appropriately. So, by this, I mean when we talk about ABCs of pain management and assessment, its main important is how we assess it. And often, as I said, that with varying age group that we have, asking about pain itself becomes challenging because some children may not be able to report. But there is a way that we can help you out with. So there are some techniques which is either a subjective experience of pain, self-reporting techniques, but this is not always achievable, as I talked about developmental age, or the child will be very sick to be able to tell you, or the cognitive ability. So in that situation, we have two ways to look at it. In if self-report is not possible, or to help you in conjunction with it, is look for behavioral signs or physiological signs. Physiological signs, we look at whether what's the heart rate, what's the BP, what's the respiratory rate, what is the child's positioning in bed. All of that we will assess. At the same time, we look at behavioral in terms of consolability. Is the child calm down with the parents at the bedside or not? So on and so forth. So when we talk about children and pain, now, again, all children are different. They may not be reporting the same thing. Same two children undergoing the same kind of therapy may not experience the same symptoms at all. They will have a completely two different trajectory in how they experience the illness and uh, their cancer journey. So it may depend upon a lot of these factors that will come through. So when we talk about assessment, it is about believing when the patient says or the child says he or she is in pain, and we look in terms of the subjectivity and non-verbal cues. So when I talked about behavioral times, when I talk about assessment and how they report, this is a chart that we generally follow in our practice for you to be able to assess, or assess how the child will be able to report. So generally in a child from neonate to 2 years, we look at behavioral signs. They start verbalizing slightly from 2 to 4 years. Maybe they'll tell you that it hurts. They might just tell you that, or they might use words that their parents would have used, say like, ouchie, or there's a boo-boo, or there is something I've got hurt, and they will use their own words in their own language, vernacular language, or the parents would have made up some funny word for them when they have pain. So it's important to ask the parent, what is it that the child says when the child is in pain? Or what do you tell the child is in pain? For you to ask that. Otherwise, they'll be absolutely confused when you say, do you have pain? By 5 years, they're able to at least tell the intensity, whether it is very little mild or it's very severe. They only know two types, binary. They'll not be able to grade it over mild, moderate, severe, or very severe. But they'll only tell you binary, whether it's mild or very severe. Then later on, 6 to 10 years, in that time, they'll be able to differentiate intensity, that they can tell you when it is mild versus when it is very severe. And does it increase with something? Does it come down with something? Where it does it travel to, and how it hurts, why it hurts, they'll be able to tell by 10 years. And beyond 10 years, they'll give you a complete comprehensive history in the character, intensity, radiating factors, aggravating, precipitating factors, all of it. So if you follow this basic chart of when you're assessing a child who might be in pain, it can help you along with using certain objective tools or certain self-reporting tools to be able to guide you to assess pain better. So when I talk about objective in neonates, we use the CRIES rating scale, which takes into account physiological changes as well as some behavioral changes, and then we score it. And along with that, you can use as a comfort, which is a behavioral score. So it takes into basically crying, physiological signs of saturation, vital signs about heart rate and blood pressure, their expression, and whether they are sleepless or they are sleeping calmly. So based on this, you can assess in a neonate. When you talk about in infants, we have the FLAC behavioral pain assessment tool, that is facial expressions, then the position of the legs, how it is, what kind of activity, is a child calm, sleeping, moves very easily, or is very fidgety, is moving or rocking in the bed, or he's very rigid, or he's completely arched, he's or otherwise if the child is jerking, what kind of a cry it is, whether they are moaning or just in between, some whimpers are there, or they're really crying continuously, or they're screaming, or they're sobbing, and they're not able to be consoled. So this has a very good sensitivity when you're assessing pain, and can really be helpful when even children who are not verbal, in children who are unable to express pain verbally, and even in children with intellectual disability where they're not able to verbally tell you, but you'll be able to assess objectively. So the revised scale, as I talked about earlier, the FLAC, the revised scoring is made for children with cognitive impairment. It has some other further features in it, but it remains the same. You to take into account the 5 face, legs, activity, cry, and consolability into picture. But there are some more descriptors used in it so that it can help you guide even more better. Because a lot of times we see children with a psychiatric illness also may not be able to respond if they are verbally, they are not able to express, or they're very irritable, or they have some kind of speech or intellectual disability that they cannot tell us, then this scale really can help you objectively assess and manage their pain. Other self-reporting tools are there. Have you seen this in practice ever, or do you use this in practice? Any of these tools? You use this. You use the faces pain scale. Yes. How easy is it, right? It's absolutely fantastic that you hand over the child this card and they're able to choose where is their pain and how worse is their pain. And it is the best measure because they're able to assess it by themselves and give us a perfect clue. The only challenge here becomes is the Wong-Baker faces pain scale. We have seen in practice is that there may be varying shades of color sometimes. And we often see that children do not see the expression of the face, they see the color. And they'll point out the color and not the face. And then that could be a little bit confusing that the child has chosen his or her favorite color on the face rather than the facial expression. So we try to go and move to how much ever we want to keep it more colorful for children, but we go for the faces pain scale, the revised one. That's because you would want to consider unbiased opinion at that point in time. It's a very fairly gray picture. They are able to then focus right on where you actually want them to focus rather than talking about their favorite colors or the favorite shape and other things. So the faces revise scale works very well for children above 3 years and older. Another thing with the other one where they have various smileys coordinating with it, sometimes they might just choose the smiley which is their favorite. They may like the smiley with the laugh, they may like the smiley with, a smile just around, and they'll choose that rather than going for actual pain score. So that could again confuse them. So best is to use the one which is lower that I've marked, that is very bland and boring. Then they focus on the question that you have asked them. So this is how we can use it at a bedside. We kind of have like a marker that can slide across, and that's how we manage. So the other aspects that go along with self-reporting or objectively assessing is their behavioral signs like posture, whether they are holding themselves very tightly, they're curled up in a fetal position, or sometimes when you try to move their arm or move their leg and movement makes their pain worse. Often you might also find that children, if they say the abdominal pain, they not allow you to touch that part of the body. They'll start crying the moment you try to approach them or you try to move them. So that's another indicator or cue that there's something that the child is going through, and it's a cue for us to dig more deeper and understand whether the child is in pain or distress due to something. So other behavioral signs would also come in place would be about remaining distressed or upset. They may continue to be expressing their distress about it. They do not want to be touched. They may hard to be consoled. Or when held, as you know, a small baby or neonate or an infant, when held, might start crying even more worse because movement or being held is worsening their pain. So, assessing based on self reporting, behavioral, corroborating with the parent's perception also would help you get a complete picture. Sometimes with interaction, if you notice that the child is not focusing, he or she is trying to shut their eye, not looking at you, looking in the other direction, or they are involved in playing in their games quietly, or not wanting to even interacting with you with their favorite games. You might show their favorite video on your mobile and they're still not interested. They appear completely withdrawn, and they won't respond even to their carer's voice, or they just have a very angry, upset look. All of this can also be changes, and you will see this often in children undergoing or suffering from chronic pain. Acutely, a child will be able to show you signs of pain or be able to tell you that the child is in pain. But overall, for a children who is chronically going through pain and painful procedures, might start developing features in their behavior which may talk about that is the child probably more depressed, more sad, will stop interacting with you, will stop behaving normally as they would otherwise be. And the carer may or may not notice this. Sometimes the carer feels that the parent feels that, oh, this is just normal. They're like this in the hospital, but at home they are very different. So these subtle changes can also give you that hint or clue that there is something wrong. And we talk about the vital signs, that is fast breathing or heart rate and low blood pressure, that can also assist you to assess whether there is pain or not. So when we talk about assessment of pain is thinking first that there is a possibility, considering how the child may express by observing, talking, listening. Use your pain assessment tools, which is easy, in the child's own language, and talking to the carer, the parent, to understand what could likely be and the cues that you can see or observe from the parent that the child is in pain. So there would be one more reason about why children underreport pain. Anyone? Why would they underreport? Yeah, to prevent an intervention. Yes. Do not want more fear. Absolutely. Lack of clarity, more hospital stay. A lot of you are answering, so I don't need to. So basically, it's about developmental and cognitive reasons that they may not know how to do it, or it's normalization of pain. or the emotional psychological factors like fear of consequences after they report pain, or the desire to be brave so that they don't want to appear weak, or they want to please the doctors also. Social influences like how the parents downplay the pain, or healthcare factors like they might report pain and then you might do a procedure or have a negative experience around it. So overall, these could be factors why children would underreport pain, and that's to be kept in mind when when we're seeing it routinely in our practice. Sure. I would hand it over to Dr. Gayatri ma'am to proceed with the next part of the presentation. Ma'am, do you want me to continue sharing or you would want to share from your end?
I think I'll do it from my end if you permit me, like so that
Yeah,
I
just
can
stop
move
there.
my way. Yeah. Thank you very much. Excellent overview. And we'll take it from there, whatever we learned from Kritika as to assessing pain. So, the focus of my presentation, again, I'm going back to the same child. And look at this child. You all mentioned, we discussed at length about the causes of pain. And here I want to stick to only the physical part of pain, not the other psychosocial and spiritual dimension of suffering. We're just looking at the physical part of it. Here is a child, leukemia, induction. He complains of back and leg pain, complains of back pain and radiating to the leg. What could be the cause of his pain? He Just the physical part of it. Bone pain, absolutely, because leukemia, we expect, since it's still in the beginning, a lot of hypercellularity in the bone, and it can cause a lot of bone pain sometimes all over the body. And Smriti feels it could be intrathecal methotrexate. Absolutely. The procedural pain and post-procedural pain. Suppose the child moved during intrathecal injection, maybe some abscess or some hematoma there. That could be the cause of pain. And Muniba Alim feels that it could be vincristine related pain. Yes, absolutely. Anupa also feels it could be muscle spasm secondary to intrathecal injection. Fantastic. So I just thought my own, like a few thoughts about why this child might be having pain. One, as you mentioned, all of you, like it could be bone pain, and very well already explained the procedural pain. It could be bleed. Many a times, these children, when they bleed into the joints, and that is the reason they refuse to get down from mother's lap. They become curled up. They may small bleed maybe into the knee joint or the hip joint, and that can lead to a lot of inflammation and pain. So another strong possibility is neuropathic pain, because many a times when you have leukemia, you have intra-abdominal lymphadenopathy, and it presses on the para-aortic plexopathy, plexus nerve involvement, and that can lead to radiating pain to the leg. So there's a high chance that this may be a neuropathic kind of pain presentation. So do you think in a child there can be multiple causes of pain, like not just bone pain or not just bleed? It could be combination of many things. Absolutely. So we all agree that it is a typical cancer pain. Often it is a complex pain condition. It's not just the one cause of pain. It's often the combination of it. So why do you think it's important to know that this understanding that the cause of pain, that it's a different kind of pain, and often it is in combination? How does it help us understanding this aspect of pain? How is that going to impact our intervention? Yes, Dr. Amit says better pain management, holistic care, multimodal, absolutely. And even when you just look at the physical part of it, when we are thinking about analgesics, Anupa feels need to be addressed. We provide to be symptomatic, symptom control. Yeah, very important factor, Dr. Kritika feels, correcting the correctable. Can we still correct something? Because somebody is having back pain and child has hematoma there or muscle spasm. So I may try to correct the spasm instead. No point in adding opioids here. So looking at the cause of pain and defining, understanding, and then planning your medication management depends so much on your this aspect of assessment. And is there anything I can still correct? Suppose there is an abscess, I may have to treat the abscess. So correcting the correctable, of understanding the cause of pain, and addressing the specific cause of pain by means of your intervention is what is going to make you good with your pain management. Pain in children, unlike adult, you'll be surprised that pain is maybe there because of the disease. More common what you see in children with cancer is pain because of procedure. Sometimes procedural pain is more common than the disease itself. In adult, most of the cancer treatment, it's not so invasive. They undergo radiation and then surgery, and then it's over, and then it's mostly radiation. Whereas in children, it's most common, it's leukemia and lymphomas, and they undergo number of procedures prior to establish the diagnosis, prior to chemotherapy, after chemotherapy. So many times they're undergoing so many procedures. These procedures are short-lived, but it is so painful, and it has a huge impact on their quality of life. So, and when you talk to a child, what is that they just don't like about the hospital? What is that the most difficult experience during a cancer treatment? They'll say it's most traumatic is the painful procedure. That is the one thing which remains in their mind, and it has a serious negative impact on the quality of life. When children experience pain, a lot of physical disability, like they stop playing. Playing is so important for a child, and the child stops playing, that means something is seriously not all right. If your child is playing, you know that child is fine. Unlike adult, they'll be gloomy, they'll be complaining. But children are not like that. Once they're better, they play and they're all right. Whereas if the child is not playing, curled up, refusing to get down from the bed, it's really, that means there's a serious level of distress, and it leads to a lot of emotional distress, anxiety, depression, sleep problems. And many of these children are still, we expect them to go back to the school, but because of this poor pain control, there's high chances of school dropout, isolation, because they feel isolated from their peer, and also frequent hospitalization. All of this leads to very negative impact of quality of life. And long-term implications, many of these children, when they experience painful procedures, so we are talking about cancer, they say a procedure like vaccination, immunization, when your child is undergoing the process of immunization without much pain control, extremely painful experience, they, when they become adult, they develop chronic pain presentations, chronic pain behavior. So it's a lot of studies around that, how pain experience in childhood leads to chronic pain behavior in adulthood. Like we see patients like back pain, neck pain, fibromyalgia syndrome. So all these are probably because of this experience in their childhood. And also it leads to a lot of post-traumatic stress disorder. Many of the survivors, when we speak to survivors, children who survive, and we expect those children to get all right. And when they become an adult, when you talk to them, what they remember is always the painful procedure which they underwent. And still they, many of them, they describe how they still wake up from as a nightmare from their dreams, feeling that it's still happening again and again. So that is the reason so much importance we have given in this entire workshop, training about discussing pain. The World Health Organization, a lot of our reference is from this guideline on chronic pain management 2020, and they very clearly they say that the pain management of pain, the all evidence directs towards biopsychosocial and multimodal approach, which you already put in the chat. I totally agree. The recommendation, the evidence is all indicating multimodal approach to pain. And multimodal means, of course, the pain management by means of analgesics, but also disease-directed treatment, adjuvant medications, physical modalities, psychosocial modalities, interventional pain, all of this together, we have to see what is that we can do to improve the overall experience of the child. And it's an integrative approach. You cannot have, okay, I'll do pharmacological management and then I'll do non-pharmacological. It should not be. It should go hand in hand. It should be together. So now just next few, maybe 20 minutes, I'll just focus on the pharmacological part of the pain management, because that's the most important part which we consider when we are actually day-to-day practice when we are seeing a child in pain. So I want to do a poll here, and I want to take help of Vinila to do a poll. Vinila?
Yes, ma'am.
I encourage all of you to respond to the poll which Vinila is going to project. The question is, what are the two most commonly used analgesics in your practice? Sorry, there's a commonly used analgesic in your practice. Vinila, if they can crawl down near themselves.
Yes, ma'am, they can.
Good. So 22 out of 42 have responded. Please, I encourage all of you to.
They are not able to choose two, it seems. They are able to only mark one.
Like you mean to say diclofenac?
No, they are only able to mark one. The poll is not allowing two options, only one option. So I think that's why the maximum applied for paracetamol.
Okay, okay. Vanilla is,
Oh, sorry about that. Let
yeah.
me just check.
So, yeah, so 35 still, maybe if few more people can attempt, just to get a feel of like what is the general practice across practicing oncologists as regard to pain management in children. And the trend is quite predictable. Like I think we all agree, it's very predictable. I see the maximum response coming in for paracetamol, followed by tramadol, and then ibuprofen and little bit of buprenorphine and morphine. I'm surprised that some of you have even chosen morphine. I'm quite surprised, but definitely it is not so commonly used. There's a buprenorphine, tapentadol, and tramadol. Interesting. Thank you, Vanilla. And so, can we stop here? Okay. So I'm sure all of you, maybe most of you, if not all of you, you must be familiar with this three-step analgesic ladder. This was introduced by the World Health Organization way back in 1986, and this was for adult pain management, cancer pain management. And they said when you see a patient with cancer, it's an approach. It really helps us to decide what analgesics will be helpful for a patient who is in pain, cancer pain. So it consists of three steps: step one, step two, step three. Step one, non opioids. Step two, you may continue non opioids, but you add a weak opioid. And step three means strong opioids, continue non opioids plus minus, but instead of weak opioid, we add a strong opioid. And adjuvant medications, it goes along all the steps. Adjuvant medications means the medications which we use as a secondary, not a primary analgesic. Suppose you use steroid as anti-inflammatory, that will be considered as adjuvant medication. Suppose you're prescribing NSAIDs and you're adding proton pump inhibitor, that will be considered as adjuvant medication. Sometimes we also use drugs to manage the side effects, that would also be considered as adjuvant medications. So that goes along the step one, step two, step three. And how do we choose this step? It is based on, remember that does not depend on the disease status. The step we choose based on the severity of pain. A child with early cancer presenting with severe degree pain, like the child which we saw scoring 8 out of 10, that is a severe degree pain, I'll choose the step 3 of the ladder. Suppose a child in a late stage cancer presenting with a very mild degree pain, I'll use step 1. So for mild pain, step 1, moderate pain, step 2, severe pain, step 3. This is how we use the ladder. It's a very sliding ladder. Suppose a child with mucositis, severe mucositis, can't swallow, and you put the child on strong opioids. After mucositis resolves, we can come down the ladder from strong to weak to we can come back to non-opioids. So this is a very sliding ladder. We can go up and down, and severity determines which step of the ladder you want to choose. So this was a ladder which was described for an adult cancer patient. Let's see how we can apply this in children. Now, when I say non-opioids, we mean non-steroidal anti-inflammatory medication and paracetamol. Paracetamol, like it's one of the favorite for all of you, obviously, is one of the excellent analgesics. It works by central prostaglandin inhibition. It's excellent analgesics and much safe, one of the safest drug which we can use in children. But we have to use it adequately, depending upon the dose. Whatever dose is recommended dosage in a proper recommended times. Like at least you have to try 4 to 6 hours before we say yes, paracetamol is not helpful. So it is an excellent analgesics, but it has to be used round the clock based on duration of action and its recommended dosage. It's not like fever you use whenever you get it. Many times the family gets confused because they're all very familiar with paracetamol. So you have to be very clear when you explain to the family you're using paracetamol this time for pain and it has to be taken round the clock. It cannot be SOS medication. Among non-steroidal anti-inflammatory drugs, we have so many NSAIDs in the market. Some are very traditional, non-specific, depending upon how selective their COX inhibition. So non-specific means non-selective COX inhibitors, like all of these drugs on the left side. And as they become more specific COX inhibitor, we have selections for partially selective and highly selective. Why I projected these names is because which NSA to choose, it's your favorite. Like the NSA, I'm sure all of us, we use NSA every day in your practice, but what to choose depends on your comfort of your using it. But remember that especially children with the bleeding disorders, low platelet count, we should be very careful about use of NSAIDs. But sometimes a child, when he bleeds into the joint, and it's a lot of inflammation, your opioids will not be helpful here. Sometimes paracetamol also is not enough. Sometimes we are forced to think about using NSAIDs because it can cause dramatic pain relief. But then the platelet, we are not very sure about the platelet count. Better to go for, sometimes we use highly selective etoricoxib just for few days, 2 3 days, just to tide over acute pain of the child with the bleeding in the joint. So that's where but when you're using NSAIDs, you have to be mindful of child's bleeding parameters. So I'm not going to details of the dosage. So, but remember that the World Health Organization recommends all of these medications well studied in children, and you can use paracetamol, ibuprofen, naproxen, and ketorolac. These are all they say that we can use for children with mild degree pain. I saw in the poll that when if you're using ibuprofen, yes, excellent, because ibuprofen is one of the oldest, most well-studied NSAIDs. Whereas the newer NSAIDs, we still don't know. Many of them, they caused problem when we used in a larger population. So, but ibuprofen is one of the most traditional, safest NSAIDs. Different opioids which is available in India, weak opioid and strong opioids. And many of you, I saw that very popular, you're using tramadol in your practice, and other opioid, tramadol and tapentadol, they are similar group. So I didn't write tapentadol, but yes, tramadol, tapentadol, same group. Codeine, buprenorphine, these are considered as weak opioid, step 2 of the ladder. Strong opioids are morphine, fentanyl, methadone. I'm talking about chronic pain, and we are talking about use of medications in chronic pain. So these are the opioids which are available in India. Now, even though all of you showed in the poll, after paracetamol, your favorite drug is tramadol and tapentadol. Now, this is something we have to be aware of. Of late, many countries, they're doing away with using codeine and tramadol. What they found is that both codeine and tramadol, they are metabolized in the liver, cytochrome P50 enzyme system. And what they found is a lot of inter-individual variability. Some are slow metabolizer and some are fast metabolizer, ultra fast metabolizers. And between different races and between individuals. And that it can be, suppose a child is, if you're using tramadol on some child and it is a slow metabolizer, what will happen is it can cause excess drug level in the body and it can be harmful for the child. And we can't afford to have that kind of fluctuation in different between the child, such unpredictable action. So more and more, both, and codeine and tramadol, both, they found that it is not so a great idea to continue to use, knowing that they have such pharmacokinetic aspect which we should be mindful of. Even FDA has come very strongly on the use of tramadol in children less than 12 years. They said it should not be, children younger than 12 years should not take tramadol or codeine, which pose a serious risk for slowed or difficult breathing and death. Now this, because if they are not metabolized properly, it can remain in the system and it can cause problems. So this is the consensus, and more people are doing away with tramadol and codeine. Many of you showed in the poll that you are using buprenorphine, and which is a very unique drug. It's a partial agonist on mu receptors. It is an opioid, but it has a classic thing about ceiling effect. That means we don't have that flexibility with buprenorphine. It is a good analgesic because it is, even though it is very potent compared to morphine, but if you increase the dose of buprenorphine very rapidly, you hit the ceiling. That means the patient starts showing side effects, but you will not get pain relief. So the window is very narrow for buprenorphine, unlike morphine, which we'll discuss. We can't go much up, titrate much with buprenorphine, especially in children. So buprenorphine, that's the reason it comes with its own problem. We have various preparations. I think all of you are more familiar these days with transdermal patches. So one patch works for 7 days, and various strengths are there. It is found to be quite useful in children. There are some studies recommending that it can be, buprenorphine can be used. It's very non-invasive, easy to use. So, but it's because of the ceiling effect, it is considered as a weak opioid, and it is in the step 2 of the ladder. But generally, and you know that how these patches work. That's one of the problems of patches. When you apply this patch, if you see this on the skin, and the drug is gone from the patch, and it creates a subcutaneous depot. It gets deposited in the subcutaneous tissue, and from there it's absorbed into circulation. The problem is that if I apply a patch and the child becomes drowsy, and if I remove the patch, the child will not come out of that effect immediately because the depot is still there and it will continue to release the drug. So I'll be very careful about using such patches when I have a very unstable kind of pain and I'm not sure about the child's opioid requirement. I'll be guarded about use of patch. So that's one big problem about using such patches. So generally, the trend is, because codeine and tramadol anyway, it's like people are phasing out, and buprenorphine also with patch, it has its own limitation, even though it is a good drug. More and more people are talking about 2-step analgesic ladder instead of 3-step when you're managing pain in children. That means you start with non-opioids plus minus adjuvant. Pain is not better. Straight away, they're recommending to go to step 3 of the ladder. Go to strong opioids plus minus adjuvants. Sorry. So how long does patch take to, Dr. Nikita has a very good question. And how long does the patch take to act, and how much does it last after removal of patch? So generally, any patch you apply, like there are 2 kinds of patches which you generally use in a practice: buprenorphine patch and fentanyl patch. So patch takes at least 12 hours. Dr. Sunita, not even 3 to 4 hours. It takes at least 12 hours before really we reach the therapeutic level. So until that time, we may have to have a backup. So if somebody is in acute pain, if I apply patch, it is not going to be helpful for me. I have to have a backup, apply the patch wait for 12 to 24 hours actually, till we know, okay, is the child is all right with the patch or not. Same way, like I said, even if I remove the patch, the child may still have drug in the system for at least 12 to 24 hours. Until that time, you have to be watchful. So generally, it's not a good idea when unstable, very unpredictable. Yes, unless you're he has a stable pain and this is the opioid requirement, I will go for a patch, because once you apply a patch, you don't have to give the pill frequently. So that is the whole idea. So step two of the ladder, like I said, we have step one and step two, straight away strong opioid. And morphine is the drug of choice for severe pain in children. World over, globally, this remains the drug of choice. Often it brings a lot of apprehension among many of us, but let's understand this is the drug of choice. And we in India, we have various preparations, 10 milligram, 20. So we have IR preparation and SR preparation. IR means immediate release, SR means sustained release. IR means it's a the morphine works for 4 hours. So when you're prescribing IR morphine, it has to be given 4 hourly. So any child about 2 years, I would say you have to prescribe morphine 4 hourly. There's no compromise this side because I give I write IR tablet 10 milligram, one in the morning, one in the night, because I'm very scared to use morphine. What will happen is the child will get pain relief for 4 hours in the morning, and then he'll suffer for a considerable period of time before he gets the next pain relief. So that doesn't make sense at all. It's a pharmacological nonsense. So when you're writing IR, it has to be given 4 hourly. So remember that. SR means in India, most preparations are BD doses. That means 12 hours. It works for 12 hours. So these are the different formulations which are available in India, which you use in terms of oral morphine. How do you prescribe? Morphine, like I said, let's talk about immediate release. Normally, the standard prescription which you will see, suppose Dr. Kritika is sending a patient on oral morphine, you will see her prescription consisting of morphine 4 hourly, double the dose at bedtime, and PRN dosage for in between pain. Typically, cancer pain, always there's a chance that they'll have increased pain some point of time. So we always, what we do is, the baseline 4 hourly will continue. Like suppose I'm giving 10 milligram morphine 4 hourly. Now, if you count 4 hourly, like 6 a.m., 10 a.m., 2 p.m., 6 p.m., 10 p.m. The next dose comes 2 a.m. So every day, imagine you're waking up the child to take the 2 a.m. dose does not make sense. So what they found is that if you give double the dose at bedtime, you need not wake up the child in the middle of night to give the drug. Even the parents can sleep peacefully. So the recommendation is give 4 hourly in the morning. In the night, give the double dose at bedtime so that the child can sleep, and the next early morning dose 6 a.m. Even if the empty stomach, they can give, no problem with empty stomach dosage. And always explain to the family the importance of giving PRN dosage in between. Suppose you give a drug at 10 a.m. and next dose is scheduled for 2 p.m. 12 p.m. if the child gets pain, please give extra dose of morphine. So this is how the prescription looks like. 10 milligram morphine 4 hourly, 20 milligram bedtime. And usually we say same dose, because if you say 5 milligram, half the dose, parents get confused because already we're talking about too many medications. So I would say 10 milligram 4 hours, 4 hourly, 20 milligram bedtime, and 10 milligram PRN dosage for the breakthrough pain. But the next scheduled dose should be taken as it is. I hope you get my point. Suppose the drug you're giving at 10 o'clock, next dose is at 2 o'clock. 12 o'clock child gets pain. So I'll give extra dose of morphine at 12. But the next 2 o'clock I should not skip. I should continue with giving the schedule as per the schedule. Because if the family start counting 4 hours from the time last time they give, they get confused. So don't break the schedule. Keep the schedule and give in between the PRN dosage. Now this really needs, we spend a lot of time explaining to the family the medication. The medication education is so important for the family. And like I said, unlike buprenorphine, morphine has a wide therapeutic window. We can go on increasing the dose of morphine. So we titrate each time. So when you suppose with 10 milligram patient is not better, next time I'll increase by 50%. So the next dose will be 15 milligram Q4H, 30 milligram bedtime, and 15 milligram SOS. Like that, I keep on increasing. The upper limit will be either the child gets good pain relief or the child starts showing some side effects, which is not acceptable. So until that time, we can go on titrating, like every 24 to 48 hours, we can see and titrate. So this is how we titrate the opioids. So you really need really hands-on training to understand this a little more in detail. But you may see the prescription. So you must be able to understand why it is being given like that.
Ma'am, there are two questions.
Yes.
One is by Dr. Sunita asking about the patch. Does absorption change with temperature?
A very excellent question. Yes, I was hoping to cover that in fentanyl. Dr. Sunita, is the patch when you apply on the skin, and the skin vascularity really determines how much drug to be absorbed. So, classic in warm weather, there's a lot of congestion on the skin, trying to lose heat. There's a lot of absorption of the drug. So, in the heat, sometimes the patch may have a very unpredictable absorption. So, yes, your answer to that question is yes, I would say. So the next question is, how do you decide the baseline dose? Shruti, let's come to that. Generally, most patients, when you see a child in your OP, they are not opioid naive. They would have tried some drug opioid somewhere else. If that is the case, I'll just use the conversion chart. Everywhere it is available, tramadol to morphine conversion, codeine to morphine conversion, we'll just use that. If the child is opioid naive, then we start with 200 to 400 microgram per kg body weight as a starting dose. So yes, the initial starting dose can be like this. 200, I'll come to that, and then we increase the dose. So Aarti says, does the effect of patch weans off with time? If it has to be changed next 5 days, do we have to pain on? Yes. The patch, depending upon the duration, suppose you're using buprenorphine patch, by seventh day, we usually, when you apply a patch, we mark it on the patch, the date of application, so that we remember to change it on the seventh day without fail. Otherwise, the child will increase pain. If the child is having more pain on day 5, then I guess I have to remove the patch and think about some other strategy to give pain relief, also understanding that he has some drug still in the system. So I'll use with smaller dose smaller dose of other opioid, and build up on that. So yeah, it is a little complicated, Arti. If the child develops pain on the 5th day and then you need to remove the patch, then how to calculate the dosage. So yes, so that's the reason I recommend don't use patch when the pain is still not sure about the opioid need of the child. And that's another, Dr. Upasana very rightly you pointed out. The biggest problem is that as a very small child, we don't have smaller dose patches. We cannot use it. That is a limitation, another limitation. And the pain, we don't apply patch at the site of pain. Dr. Reddy, no, it has nothing to do with the site. It will get absorbed into the system. First, finally, the action is the drug in the blood, not at the site. The drug gets absorbed into the blood circulation and it produces its action. So it has nothing to do with where you apply. Normally, we also where to apply patch is a big thing. We apply patch where there is less hair growth, less sweaty, and where you can stick the patch easily and it is not rubbing and the child is moving, it should not come off. So usually the common site is upper part of chest, upper part of the back, maybe over the arm, upper part of the arm. These are the site which we choose. We can use also the abdominal wall. So yes, Kritika, can you show the conversion chart on the web chart? If you can just download somewhere and
Yes,
show.
yes. In the background, I'm doing that only, ma'am. I'll
Right.
share in a while. Yes.
So, Nikita, some companies they say because of this the modern preparation how they make the patches these days, they say that you can cut the patch and apply. But normally, most of us, Dr. Archana who's here, I'm sure Kritika also, we don't really like to cut the patch and apply. We are not sure how reliable the absorption would be. But the company says you can cut the patch and apply because the modern preparation is like that. Yeah. So, if once the patient is stable on oral morphine 4 hourly, I can convert this into sustained release because child need not take 4 hourly. So what I do is, suppose patient is on 10 milligram morphine 4 hourly, 20 milligram bedtime, I'll convert into what is the 24-hour dose? If it is 10 milligram 4 hourly and 20 milligram bedtime. 6 doses into 10, 60. 24 hours he needs in 24 hours. So what will be the conversion? So conversion will be 30 SR-BD. But remember that SR tablet does not work immediately. But so for PRN dosage, again we have to use IR preparation. So my typical prescription for sustained release is 30 SRBD and IR-PRN. Yes, I see a hand going up. Yes, doctor.
Sorry, Gayatri, I was just trying to say, so does that mean that we should initially start with an immediate release, try and see what is the total daily dose, and then switch to sustained release? Will that be, a way forward or just a...
Absolutely, Dr. Shruti. I would say let's start always I would say till we have very confident and I can offhand just like that. I'm looking at the child. I know that's very unlikely from all of us. Always we start with IR tablet, titrate and see what is the dose requirement for the child. That's the safest approach. Start small, go slow, titrate, and determine once you know what is the dose requirement, then you can play around. Okay, let's convert to sustained release, let's convert to patch. We can do that. But playing safe is always better to start with IR tablet, and that is a recommendation. And this is the like kind of we'll be sharing this with you, all of you, this PPT also. So this is what taken from the WHO essential drug list recommendation, the dosage of when you're giving oral, IV, sub-Q. This is how we give. Transdermal patch, many of you must be very familiar with this. Very popular among oncologists to use transdermal patch. Again, quite safe, effective, well tolerated in pediatric cancer pain, especially in renal failure. Now remember that, and remember renal failure, morphine metabolite, if gets accumulated, in morphine does not have a problem when there's a damage to the liver so much. Morphine is metabolized in the liver and it is converted to morphine 3 glucuronide, morphine 6 glucuronide, and both are active metabolite. So if liver is not functioning well, the active metabolite is not formed, so not a problem. But if the kidney is not functioning well, this active metabolite get accumulated in the body and it can cause problem. So you get my point. Morphine, it's metabolized in the liver to a very active metabolite. So it is more a problem when there's a renal failure. So I'll be using with great caution morphine in children with renal failure. So I'll always look for an alternative. But if you don't have an alternative, you can still use morphine, but in much smaller frequency. What we do is, that is one indication where we don't use morphine 4-hourly. We'll use morphine 8-hourly or 6-hourly when we have a renal failure child. If you have an alternative, we'll switch over to other drugs. So one of the drugs which we switch over to is fentanyl patch. Very safe, effective, well tolerated. And especially when a child, suppose severe mucositis, and a child no more can swallow oral morphine, I'll switch over to fentanyl patch. Suppose a lot of vomiting is there, compliance issues are there. That's a situation we use fentanyl patch. Again, we have various preparations. Limitation is that if you need much smaller dosage, we can't use the patch. And some problems which we already discussed, not useful for breakthrough pain, latency of action, and even after removal of patch, the drug remains in the body, erratic absorption in summer. Very important aspect is so expensive. It will be 20, if you calculate dosage, it is 25 times more expensive. So that's something we had to be mindful of, because we always talk about pharmacoeconomics. So patient who needs long-term fentanyl patch, I would not recommend. Whereas morphine is very cheap, less than 1 rupee it costs if you buy in bulk. But fentanyl patch, even the 25 typical 25 microgram patch cost easily around 500 to 900, like depending upon the company you're purchasing from. So that's something we have to be mindful of. But if the patient can afford it, because the hospital supplies it, I would love to use patch in certain situation. So morphine SR tablet 12 hours, Dr. Hasina. So we use BD dosage. So like I said, BD dosage we use for sustained release tablet. Now, as an oncologist, I request whenever you see a child in pain and coming with morphine prescription, please always make this extra effort to take the tablet which they are carrying and read whether it's IR or SR, because it's written in a very small letter, and if you don't realize it is a SR tablet and you give SR as 4-hourly, it can be disastrous. So I've seen many times major problems happening when the oncologists don't realize that it is SR or IR. So please always you mention IR or SR when you're writing prescription for morphine. One alternative which we have in many of the centers where we have a robust palliative care program is methadone. Excellent drug, again very safe in children and safe in renal failure. And methadone is specifically we use for complex pain conditions when you have multiple issues like the classic example which we saw this child. Suppose a child has neuropathic pain, bone pain, everything together. Sometimes morphine may be partially responsive. They don't really respond so well to morphine. Then sometimes we rotate morphine to methadone. We have syrup formulation as well as tablet formulation. But using methadone, you have to be very cautious. It has a side effect profile which is like we have to be very well aware of, because it causes QT prolongation, and there are instances of sudden death happening because of that, especially when you're using with some drugs which can change the metabolism of methadone, or already there's a background history of cardiac some anomalies. So we have to be very cautious about use of methadone. Similarly, some methadone has a very long half-life. I start a child on methadone today, the child will be peaking the action after 5 to 7 days. You may not even see the child may go home. So those are the few things which you have to bear in mind. So I'm not spending much time discussing methadone today because it really needs a separate level of session and class to understand methadone and really hands-on training. But remember, for all opioids, oral morphine is a prototype. I really recommend you all get familiar with oral morphine. Once you're confident about oral morphine, then you can play around with other opioids more confidently, because then you know the opioid requirement and how to titrate and what is a conversion. Kritika has already shared the conversion chart. We can just use the chart to convert from morphine to fentanyl, morphine to buprenorphine, and like that you can use the conversion. Dr. Reddy, fentanyl patch typically works for 3 days, 72 hours, unlike buprenorphine, which works for 7 days. So fentanyl patch is more like every 3 days we have to change. This is how Dr. Kritika has already mentioned. Thank you, Kritika. A quick poll. I know that we need less time, but a quick poll, Vinila. Next poll.
Yes, ma'am.
What are the two biggest concerns you have around use of opioids like morphine in chronic pain? I've listed out many problems, but what are your concerns around the use of opioids? Excellent, very interesting trend we are noticing. So the biggest problem you're considering is constipation, and very interesting. Respiratory depression, yes, I would be worried. Let's discuss that more. Tolerance, addiction, nausea and vomiting, and deaths, sudden death. Interesting, actually. Yeah. Thank you, Vinila, for this poll. So we have some idea about the concerns. Now let's talk about some side effects of opioids. Now, these are the common side effects of opioid. When I say opioids, it covers everything, not just oral morphine. Often, for everything we say oral morphine is bad. What we don't realize is all opioids, they share similar property. Whether using buprenorphine, tramadol, codeine, methadone, fentanyl, or morphine. All of them, they share the same property because they all opioid, they work on the same receptors. So the most common side effect of opioid is constipation. And whichever opioid you write, you must remember to write a laxative. And the laxative of choice is stimulant laxative, like bisacodyl. You may plus minus add softeners, but constipation is one problem. And as long as you write opioid, constipation may be there. The other less common is nausea and vomiting. That too, nausea and vomiting usually in the initial days of starting opioid, a child is opioid naive. When you start initial days, they may experience nausea and vomiting. After some time, they develop tolerance to actually nausea and vomiting, not to constipation, but to nausea and vomiting. So you can stop antiemetic later on. And the drug of choice for opioid-induced nausea and vomiting is not ondansetron. It is dopamine receptor antagonist drugs like metoclopramide or haloperidol. And other less common are initial drowsiness, itching, or urinary retention. So these are the side effects of opioid, which applies to all opioids. So constipation, please remember today when you go home, remember opioid constipation. And less common is nausea and vomiting. Now, toxic effect is something we must worry about. Toxic means when the level of blood in the blood is above the therapeutic level. Side effect which you see even at the therapeutic level, you may see the side effects. You don't stop a medicine because you got the side effect. But toxic effect, you have to worry because either you reduce the dose or you have to stop the medication. The three common side effects toxic effect which we see is undue drowsiness, myoclonus, delirium. Undue drowsiness means typically parents will describe the child is so sleepy, he stopped eating, he's not getting up from the bed, too much drowsiness. Then you're worried. Then myoclonus, abnormal sudden jerky movement of the hand. The parents will describe, I don't know why of late suddenly he's having such jerky movement. I will be concerned that maybe I'm reaching the upper limit. And delirium. Typically, and we miss this sometimes. The parents, unless you ask, they will not even tell. They won't even recognize that it's because of drug induced. The child will become very confused, agitated, forgetful, irrelevant talk. So if you notice, think, is it because of opioid? That means you have to reduce the dose of opioid. Respiratory depression is a very unlikely event because before that you develop all of these problems and you'll recognize something is not all right and you stop medication. Respiratory depression is a problem when you give injectable opioid in a calculated dosage, just push the like zero point 0.2 milligram per kg body weight, push, then the child may have respiratory depression. Or deliberately, if the too much of tablet is consumed, which does not happen in children normally, because before that your child will develop delirium and the family will automatically they'll stop giving opioids. So it's a very unusual event to have respiratory depression in our clinical practice because we titrate, bring it up very slowly. Again, addiction. Several studies have shown, and this is the WHO guideline recommendation, when we use the appropriate medical use of prescription pain medications such as opioids, when properly monitored, does not lead to addiction in young children and adolescents. So it's quite a safe medicine to use in palliative care need when there's a palliative care need. So we are not talking about non-cancer pain conditions. We are talking about cancer pain condition. And when there is a pain, we can very safely use opioids. All pain cannot be treated with morphine, like we discussed. Suppose there's a bone pain and a lot of inflammation. Morphine it does not have anti-inflammatory action. Suppose there's a muscle spasm, skeletal muscle spasm. Morphine does not, we rather use skeletal muscle relaxant. Spasmodic pain in the abdomen, I'll use smooth muscle relaxant. So these are all, we use adjuvant medications when we think it's a pain causes something different. Neuropathic pain, it's often opioid semi-responsive. Sometimes we have to use other medications like tricyclic antidepressants, gabapentinoids, and alpha agonist drugs for neuropathic pain. So these are the different adjuvant medications which we use in pediatric pain. Various non-pharmacological approach which should go hand in hand with pharmacological approach which Kritika already mentioned, like rocking, massaging, music therapy, calm environment, sleep, and distraction techniques, CBT. These are the few things which we can think about as a non-pharmacological, which should go parallel with pharmacological management. I stop here and I request Kritika to quickly tell us a little bit about procedural pain before we take question. Okay, Shruti says we have an adolescent boy who has history of opioid use disorder. What would the drug of choice for pain management in such a situation? First of all, opioid use disorder is a diagnosis which we have to make very carefully because many times when there's a drug seeking behavior, often it is because of drug unrelieved pain, improper or improperly managed pain. And the child is desperate to get pain relief, so they ask for more opioids. So we call it a pseudo addiction. So
Father,
yes, Shruti.
normally the father also has history of drug abuse,
Okay.
and this is before the diagnosis, not
Okay. Okay. Shruti. Yes, we see more and more these days adolescents trying drugs and they do drugs. So once you have the history, still if the child is in pain, we'll not deny opioids for those children. Only thing is normally, when we prescribe opioid, we talk about universal precaution, like things like pill counting and give small number of drugs, constant follow-up, single prescriber. So these are kind of things which we follow up for all children, all opioid dispensing centers. All the more when we have a history, drug behavior, opioid use disorder behavioral history, we'll be more cautious. Then we all the more very strictly we document, but still will not deny pain relief to that boy, and we'll still prescribe opioids. And if the child is on particular drug, which suppose is used to taking heroin or particular drug, then we do opioid rotation. We switch over to other opioid to bring him out of that drug and then use other opioid to give pain relief. But it needs a little much more specialized approach to management. But the bottom line is, if he has pain, he still needs opioid, but under controlled situation. Kritika.
Ma'am, I'll just share the slide.
Sure. I'll stop sharing.
So just to add on to what we discussed initially about that, we talked about procedures and various types and causes of pain. Now, this is one of the most debilitating issues that children often do not want to turn up to the hospital, will refuse treatment. Parents get distressed that the child is not turning up to the hospital, is afraid, and this one of the reasons would be is procedural pain being inadequately managed. And by procedural pain, it is not just the physical aspect of it, but it's also the anticipatory anxiety that they start developing. I mean, if the child has previously been exposed to hospital environment, has been coming frequently, they'll start anticipating that, oh, today is my IT and I'm going to be asked to lie down in such a position, or may remember that I was pinned down in a certain position, and that is what is going to be discomforting. It was very distressing for me, and they will hate it. And they'll start having palpitations, they'll start crying, they'll refuse to come, they'll not eat, they'll have different forms of presentation that they'll start becoming very nauseous. They are very anxious sitting in the OPD. All of this can happen and overall, it can just have a long-term fear about hospital, avoiding healthcare, and being having that mistrust towards healthcare staff, and a significant heightened sensitivity. Like that we call it as like the pain threshold has come down so low that they can't even bear you holding them for any procedure. Even as simple as sometimes putting a BP cuff for them to check their vitals, they will start howling, thinking that probably you're going to be using a needle prick for them the next time. So anticipating pre-procedural chain is most important, and looking at what could be the likely intensity and duration of that pain. And the most important way, or the most easiest way for us to handle that distress, is having that child being informed what procedure is going to be doing next and how it can be managed, or how it can be circumvented, or the pain can be reduced. So as a team, the child, the parent, and the healthcare staff, they form as a team together that can help reduce this anticipated pain, and feel that that they can be really provided less distress and managed well. So in pre-procedural pain, management strategies could be various. Most commonly, we recommend is using a topical anesthetic, or usually a eutatic mixture of lignocaine or prilocaine together. Comfort positioning works because that is one of the ways that a child is felt more safer in contact with their parent. And positioning could be in various ways depending upon what procedure we are doing and appropriate for the procedure. uh, as always, children can get easily distracted. But again, you have to look at age appropriate. You can't have a 15-year-old being distracted with a toy. They will not. So, depends upon the age group. You need to have methods for distraction decided about, and giving them the option between two. If you tell them there's a varied option, they will never choose, or they will randomly do something which you will end up not being able to succeed. Giving them two options which works for you and which that will work for the child as well, and then making them choose that and performing that. Neonates, infants, breastfeeding or sucrose. You must have seen at the NICUs, they will have a small cotton swab dipped in sucrose solution and then kept while they are doing a needle prick or blood collection. That itself works as an analgesic in neonates and infants. And now the most important is how we communicate to children, age appropriately again. So like someone who is 5-year-old, 7-year-old, adolescent, young adult, If you tell them what the procedure is, explain what is going to happen, what will be the sequence of events, what will be done, they'll be more receptive of you to do that procedure rather than being just asked to sit and then out, stretch out their arm and asking and getting a procedure done. They will be more fearful of it, and next time they'll be more apprehensive to get that procedure done. And always, in children, it works that if you praise them, if you reward them, they remember that. So if they have really outshined in that procedure that day, that they were very calm, they sat through the procedure, they allowed you to do it, they looked through it. Sometimes just rewarding them at the end, that maybe just a small star sticker works, and like a badge that, oh, this was, you were a strong boy or a girl today, and you were able to do this by yourself, manage it by yourself. So that kind of reinforces that what procedure has does not have a negative experience, but it counts as a positive experience for them, and thereby it improves basically nothing but their experience during their illness journey. So it's all about, all of these strategies are aimed at improving their quality of life and their experience during the illness journey. So topical anesthetics, or basically the analgesic cream, there's a simple way to do that. Often we'll apply, look at us and then, apply, and within immediately 5 minutes, the nurse is ending up doing the procedure. It won't work like that. So we always tell them apply it like just a cream, a small area where you have probably pre-identified where you want to do the IV cannulation or the phlebotomy procedure, and leave it on for 30 minutes. We say usually wrap it with a plastic wrap or a transparent sticker or a cotton tape itself, that you have that paper tape that we use it for sometimes securing an IV cannula. That itself can be applied on top of it so that it just remains as an occlusive dressing and does not kind of get rubbed away, or sometimes a child might be messing with the hand, it can get transferred into other areas. So just to prevent that, we can just wrap that area. After 30 minutes, you unwrap the sticking, you sterilize it, put in the needle for a IV cannula or a phlebotomy, and it actually works. It's magic. And we are doing this project, and it's a widely studied evidence-based practice. The 5 measures that I told you is none other than by Stephen Fredericks. He has done it at the UCSF Benoist Children's Hospital, where he first started it. And believe me, he has created a pain-free hospital in that center. And it's not that it's impossible in our setting. Currently, St. Jude, along with another institute, is doing this called as a Global Comfort Promise as a way, as a quality improvement measure to manage pre-procedural pain and reduce down the burden of pre-procedural pain. And it's being done in a lot of LMIC settings. So it is definitely doable. We can start small, make smaller changes and bring this into practice. So, as Madam talked about earlier, the non-pharmacological measures that go hand in hand with topical analgesia is distraction, guided imagery, a calm environment, communicating with them, promoting patient control, explanation, visual schedules, or sometimes using a busy bee and ice. These are just games that you can play. Or in young in infants or in neonates, using breastfeeding or procedural holding by the parent. Other interventions should be age appropriate. So these are just a basic list of it. In infants, what would work. In toddlers, like bubbles, if you have seen, just to distract a child. If you use just regular bubbles in your clinic, it can help you. Comfort holding. Then in school age children, comfort holding works, but sometimes distraction like books, toys, any video game, cartoons nowadays. I know nowadays children don't do books. They will be on YouTube shorts or videos or Instagram stories and what all that they watch. But we can still try to utilize in that situation what is something that a child would really like to see and use that as a method for distraction. Adolescents, however, value their independence and
They want to see the previous slide.
yeah,
Can you show the previous slide, they're saying?
this one.
Which one? So, Dr. Sushma, if you can specify the last line. Which one?
Was it about?
Next one, ma'am. Next one, ma'am.
Okay, 1 minute. Was it this?
Yes, yes, perfect. Okay, comfort holds. Yes, yes, yes. This one, ma'am. Thank you.
Please share the
Yeah, got it.
presentation.
Yeah.
Don't worry about the content on this. We are going ahead because we are short of time, but we will be sharing the PPT so you can freely
Okay.
use it to read
Oh,
later.
that will be helpful. Yeah. Thank you. Thank you. Thank you.
So then you have school age children, you can use comforts and video games. Adolescents, as I said, they're very hyper independent and they want to make their own choices. Some may want to show a brave face, so they'll be like, no, I have no pain, and they'll go ahead with it. It's up to you to judge you, because you know the child better for a long period of time, how they've been doing. Some may still be able to tolerate it, some may need help. So technology, using various games. Sometimes what we have in our OPD is one chart I have made, which has a sentence and some shapes and all drawn across, and we tell them how many closed circles you see on that chart, you count. So it will include the letters, the numbers, where there is O or zero or shape of zero or a circle anywhere, and I tell them to count. Maximum number of times adolescents is never able to get the exact count, and that really perturbs them, that how did I miss something? So then they are more engaged in doing that by the time you're done with your procedure. So that's how is something that even as simple as a chart where you ask them to count a shape, and they get hooked onto it, and they will do it. So basically, understanding is our take home points here is that children with cancer experience pain due to cancer and due to the procedures. So pain should be routinely assessed, screened always using age appropriate tools, because as I said, a lot of them will underreport pain to you. And the two-step analgesic ladder is the most effective to manage cancer pain, as madam has explained through her, the class that she give you really beautifully, that, gave you idea about what should be used, how and when. And morphine, yes, it is a safe and effective way to manage cancer pain. But always keep in mind also about procedural pain, though it is short-lived, but it is such a debilitating experience, or such an experience that the child remembers in life, that they don't think much about other things that have happened in the hospital, coming and going, but being exposed to painful stimulus or procedures is what they remember, and they might carry it on for the next. So I think we should all have measures to put in place to screen pain, and to have an SOP to manage procedural pain control and managing pain with effective use of analgesics. So with this, we open for discussion, ma'am.
Thank you, Kritika. I think we're almost there with the time, but there were discussions which I was parallelly chatting. Uh, there were some questions which I kind of responded.
Yes.
May I ask a question?
Yes.
That's it, Navika. Yeah,
Yes.
hi. Yeah, I just wanted to is there any comment on the effectiveness of parental presence while uh, anesthesia induction? So, for example, I have just read conflicting studies. I don't know. So, when we're trying to take the kid for intrathecal and we're trying to give short GA for ketamine Midal before the procedure, does the parental pressure, because there is always conflicting medical legally, what if something goes wrong and you want the parents out, or be allowing the parents to stay while the induction is being done? Does it have any effect? Is there any comment on that? Is what I was trying to ask. I know it has not been discussed, but that's a question that I was hoping to.
I think
Uh,
maybe I'll start and then you can fill in. So thank you, Anupa, Dr. Anupa, for this question. I also saw a chat response some time back when you said parental distress often transfers to a child and sometimes cause more problem. But most of the time, their presence is more reassuring than doing harm. Like I come from anesthesia background, and most modern theaters we recommend parents to be around just for that one reason. Until the time we do the induction of anesthesia, the parents remain by the bedside. Same thing we practice. Like I work in a public hospital now, and in intrathecal injections, like Dr. Archana is, we would work together. So she encourage, and she has very nicely, she has this understanding with oncologist. So every intrathecal injections, the parents, they are at the head end. Their role is to be just there holding on to child. But we give the choice to the parent, which parent want to be there, because many parents sometimes they feel giddy and they may faint. So we tell them who is bold enough to hold the child. And it intrathecal is again a repeated procedure. So they'll know which parent can handle that. So we give the choice to them. But it's always a good idea to have the parental involvement in all these procedures. Kritika, if you want to add anything.
No, I mean, that sums it up all.
Thank you very much, ma'am.
Ma'am, you're muted.
Thank you very much. It was a very interactive, even though we're very busy chatting. But if there are more questions, please feel free to put it on our chat group. We can always respond to your queries. Some real practical issues, if you want, let us know. We'll be very happy to help you. Over to you, Vinila and Dr. Archana. Dr. Fichi is still there.
Maybe Dr. Shruti has just commented it's only when we are teaching a resident we avoid parents. Sometimes I would say, maybe just a comment from my end on that is it's okay to have a parent there because sometimes parents know that you're in a medical college and there are other doctors who are learning and studying along with it. If it's only when you're doing an actual procedure and you're teaching something and the parent, you might fear that the parents feel that some learning doctor is performing a procedure and all of that is one of the reasons why it sometimes works that we ask a parent that so and so doctor is going to be doing it. They're at much better hands and they're confident of it. It works well. It may not work otherwise. In fact, it works well, and parents are quite happy to be in the room, even if it's a resident doctor doing a procedure.
And I think most important is you're showing them the residents actually you're training the residents to involve parents, so they have to show them that it's all right to parents be around. But the question, well, it's a very good question. We have to give the choice to the parents and the child, most important. No more questions. Vinila has and Nandini has put a request for post test. Yes, if we can quickly finish that. And like we said, it's a very ongoing thing. Please feel free to put more questions as you practice. If you come across any issue, we are happy to help you. Thank you very much for the great interaction we had.
Thank you, everyone.
Thank you so much. Those who have completed the post test and the feedback, request you all to please kindly give your feedback so that this helps us improve the further sessions. Those who have done, you can leave the session. Thank you. Those who have completed the post test, I think you can leave the Zoom link.